Welcome to the Mindset Matters, the podcast where psychiatry, medicine, and real human experiences collide through the eyes of two psychiatric PA. We're your hosts, PA Mercedes Dodge and PA Jessica Spissinger, two passionate psych PAs on a mission to bridge the gap in mental health care. So whether you're a provider just here to level up your psychiatric insight, increase your mental health skills, you're in the right place. Each episode, we shine a light on the incredible work PAs are doing in psychiatry and beyond. Our goal is to build a community focused on better patient care, professional growth, and personal well-being. A little disclaimer is for educational purposes only. We're not here offering medical advice, psychiatric advice. If you or someone you know needs support, please reach out to a licensed mental health professional. All right, guys, let's dive in. Ever since meeting you, as I've gotten to know you through our work together with APAP, learning more about your clinical interests was so fascinating to me. I've been so excited to dive into it. Part of the reason why Mercedes and I started this podcast is because we're connected within the psych PA world. And we're like, there's all these amazing psych PAs out there doing such cool things. And we're like, there's just not enough known about what we're all doing in our world. So we wanted to have this platform to bring on and invite some of the amazing psych PAs like yourself so that we can hear more about what you're doing and make sure other people know what's going on as well. Oh, I'm just so excited to have Sarah. It's been a pleasure to work with her in leadership at the Association of PAs in Psychiatry. She has a great mind, pretty on key on making things happen. So I just really want to praise you for your leadership with APAP. And I'm interested in diving in to know more about you. I want to know a little bit about your personal journey into psychiatry. Before psychiatry, you spent time in emergency medicine, maybe also oncology. Tell us a little bit about that story.
I'm going to go back even further. I have a whole past life, a whole previous career of being a speech therapist. I worked in a radiation oncology practice that had small regional offices in upstate New York, upstate Jersey, and Pennsylvania. Through that experience, I had an incredible physician mentor. One of the things I wanted to bring into this conversation, how powerful an unsolicited mentor has been in my professional life. It totally changed the trajectory of my career. And, this physician, this radiation oncologist, saw something in me that I didn't recognize in myself. His confidence in me gave me the confidence to think more broadly about, do I want to stay in this career? Do I want to try something different? And at the time I was 25 and I thought I was too old to go to med school. If someone is 25 and thinking they're too old to do anything, the old me is looking back and be like, no, I totally could have done that. But instead, I was drawn to PA school because I had this amazing mentor relationship. And that's what I thought being a PA was going to be. Had this amazing physician mentor, went to PA school, got my start in emergency medicine, found my way back to radiation oncology, loved working in rad onc. But I kept feeling like if I switch disciplines or find the right job, I'm going to find this physician mentor, this wonderful relationship where our skills are bouncing off each other. The reality is that is a total unicorn. That mentor experience is not what a supervising physician is. A supervising physician is meeting every 3 months to talk about legal licensing requirements and to make sure the liability insurance is okay. It is not a learning thing, right? I internalized this message of I'm expected to practice independently, but I still require supervision. I didn't realize how difficult and weird that was making my mental health. That
Cognitive dissonance.
for me, it's pretty ironic that the word supervision is used for a relationship that provides, and I'm talking more broadly about our healthcare system. There's no incentive or structure for this physician mentor, PA, physician mentorship relationship to exist. And so I just kept climbing the ladder, right? I kept thinking, if I get a job at this academic medical center, if I get a job supervising, if I get a job, I kept thinking I was the problem. I remember thinking why some of my colleagues can go to work 7 o'clock in the morning, leave at 5:30 and do that 5 days a week and be cool with that. I'm very much not cool with this. I am so miserable. And all of the unpaid stuff that I'm doing at night, vulnerability is power. And I want to model that to others. I was working at a very prestigious university. I had what I thought was the job. This is it. I'm supposed to be happy now. I have reached the pinnacle of career success. I have arrived. And instead, I was absolutely miserable. I used to park my car at the top of the parking garage to get my steps in. Every day, I would leave work, climb the 6 flights of stairs to my car. And one day, I looked over the edge of the building and I had this very salty voice enter my head saying, that ain't going to get the job done, meaning that
Wow.
the parking garage was not high enough. I am not a person prone to suicidal ideation, and it really freaked me out. I was working in oncology at that time, so I didn't have the mental health training that I have now. And I just got in my car and I thought, being alive is superior to being employed. And I'm an and kind of person, but it felt like a real or choice.
Yeah.
Leave this job or leave. So in true type A form, I just quit my job with no plan. This is not what PAs do. This is not all of us, I think, go to school competitive, have the checklist, have all of our moves mapped out. And I just left. I can't do this.
I am thankful that you're sharing this journey because that vulnerability, we are not all like these superheroes that have it all together. There's so many stories within the medical profession, as well as actors and celebrities. They have the best job, but in reality, it's not that simple. We have to tackle what we're dealing with and our values and aspirations and where we're supposed to be in life. And we all get through those steps, but we don't talk about it. And so that's why I also feel so empowered by stories we're hearing through this podcast. Jessica and I really wanted to show a lens that we are complex beings. That is a beautiful thing, especially when we're providing mental health care, because our stories help us connect with the stories of our patients.
Absolutely.
I've always said in our profession, we're kind of like self-selected type A's, although I personally identify more with a beta type A. You had it all planned out and then you did something different. I would imagine for a lot of people that would lead to some unraveling.
I think I felt like, well, I have already successfully gotten myself unraveled. Looking back, I realized I had been using every coping strategy I could think of to get through that situation. It was just untenable. I couldn't do it. What I decided to do was take a mental health break. And I thought, I'm going to go back and finish my doctorate. I had always wanted to do that. I had started it, I had kids and put it to the side. Thought, what is the common thread since I had been jumping around from discipline to discipline? What is the common thread in all of these jobs, plus the situation I was going through? I was like, oh, I'm going to do it in psychiatry. I'm just going to do my doctorate in psychiatry because that will apply to any discipline that I get into and I'm interested in it. So that was the best decision I made.
Now, for PAs to get a doctorate in psychiatry, that's not something that was always an option, right? Can you tell us a bit more about how you chose the program?
Actually, at that time, so this would have been like 2021. Yeah, it was definitely after the pandemic. So like 2021, end of 2021, there were not a lot of options for PAs who wanted to study psychiatry. I wanted some sort of counseling or therapeutic component, and I wanted some broad base in prescribing. And I also wanted the ability to just try before I buy. I wasn't sure if I was going to want to switch. I knew I didn't want to get into teaching, but I thought maybe the leadership thing could still work. I ended up choosing Rocky Mountain because whatever Google query I put in, reflecting everything I just said to you, that was the school that showed up. At that point, there were just so few options for PAs. I actually even thought about like, oh, I'll get a master's in counseling. That would allow me to work differently. This is a broader problem with the PA profession in general. You shouldn't graduate with 125 credits of a master's degree and then think, I should go get another master's degree to do counseling. If you want to do psychiatry, it should be rolled into the training. My experience at Rocky Mountain was incredible. I had a great training experience, particularly in CBT or cognitive behavioral therapy. I'm in private practice. I work in an outpatient setting. I own my own practice. That CBT training opened the door to pursue other forms of training like DBT, ACT. All of that training was information I could apply right away in a med management appointment. Brought so much value to what I was doing as a provider, but I think also to my patients.
I love that you put a lot of attention on what is going to get me toward what I find joy doing. I'm going to have these skill sets that I can still do more than one specialty. You didn't want to corner yourself in. And I think that's one of the beauties about being a PA, right? I loved being a PA because I have a broad amount of experience. I'm kind of a generalist, but I also can be a specialist. And that's why I truly believe all PAs are psychiatry PAs. You're going to use those mental health skills, CBT and motivational interviewing in every office, in every specialty. One of the things I want to highlight for us PAs is you got to hire us. You got to use us as leadership. Our medical training is exceptional. Like you mentioned, the hours that we have to go through training, it is rigorous.
Yes.
It is no joke. And I don't think many people know that. Even our patients, just call us doctora Mercedes. And I'm like, I'm not a doctor.
Right.
But they just care about the clinical care, right? Want that connection. And so I really think your skill set, your passion, your ability to connect with patients is because you're a PA and because you have your own story.
Yeah, I think that's so true. One of the things you learn in CBT is about identifying a client's negative core belief about themselves. I really took time when I was learning about CBT to realize that I had this negative core belief that I was not enough. A lot of people have that negative core belief, but I realized that negative core belief also bled into my identity as a PA. The PA title debate is kind of like beating a dead horse. Physician assistants or even physician associates, the title itself reinforces a negative core belief that we are defined by who we assist or associate with rather than who we are, always derived from the physician. We exist because the physician exists. And the focus of our title is not on who we serve or help. If you internalize that, like I did, low regard for myself, it's easy to fall into these CBT traps, like all or nothing thinking, right? Like either you're a physician who can own your own practice and be successful, or you're just a PA and you're going to work shift work. You can start to discount yourself where you defer to others, even though you have the expertise. Or mind reading
Evaluation.
where you assume like, oh, my patients perceive me as lesser, even though that's definitely not the case. So this title, physician assistant, really says more about the healthcare hierarchy and structure that we're in rather than our actual capability. And for me, untangling myself from that, stepping into my power, recognizing the areas that I have expertise and the areas where I need help and owning that rather than hiding it or feeling shame about it has been the key that has unlocked getting out of the healthcare system, getting away from contract work, starting my own private practice, and showing up authentically as who I am.
When was that moment when you decided you wanted to make that break and you're like, okay, I'm walking away, walking into my own thing?
It was pretty messy. There's a lot of fear about, can I actually make it? I realized that I rejected that negative core belief, which meant that I had to anchor onto something positive about myself. I want to show up authentically. I want to empower others. I want to be free and I want things to be. Those were the things that I landed on. If you're committed to your positive core values, the depression, the anxiety, the discontent that I felt was a message of I'm not living in tune with that. And so then this became more clear.
You went through the doctorate. And that really opened up this whole wellspring of thoughts and the CBT work you learned, integrating it to yourself.
Yeah.
It's like a
And
therapeutic
so,
journey
yeah,
yourself.
it is a
Like,
Totally.
parallel process.
yeah, I reflect on my journey and I think, why did I major in biology and psychology? And then why did my two older brothers too majored in or minored in psychology? All of us are trying to figure out where we are in life and that authentic person. We have to grate the story into our structure today and our future core beliefs. You can't take away your childhood or who you're raised by or what environment that was. When you start integrating that as an adult, it's freeing. Doing psychiatry and talking to patients, there's things that trigger me. I have to recognize that. In my conversations with patients, I do that like CBT, like, what is this negative thought? Is it true? What is the other thing you can replace into it that's more accurate? Your way to practice with patients just seem like it's gotten better over time because of where you're at today.
Definitely. A key piece of what sparked all of this, not just the mental health stuff with me, was that early in this process, I picked up some per diem contract work helping someone with ketamine. Another psychiatrist who was using compounded intranasal ketamine. She was gracious and kind enough to give me a lot of those patients to work with. So I fell into ketamine work, which is now I realize pretty enviable. I was really fortunate to have that opportunity. And I realized quickly with ketamine, this is very interesting what's happening with this drug, the improvements I was seeing in patients. I am unprepared to treat these folks with ketamine therapy and the actual therapy and integration of these psychedelic experiences. I definitely had to get training for that. That's the main focus of my private practice is ketamine therapy. I think that exciting time of having access to new medications, new routes of therapy that can give people perspective shifts. That's been a huge part of what I do and resonates deeply with who I am around authenticity and vulnerability, showing up for others.
Ketamine is a topic a lot of people are trying to figure out how do we integrate it into our services. You said you went through some trainings. Can you expand on that? What are the trainings that you would recommend as a PA that's I want to learn more and I want to do it in an effective and evidence-based way?
I think that's important. This is a tricky area in our profession. There is certainly addiction risk with ketamine. We need to be thoughtful about who we're giving it to, what setting we're giving it in, how much, how often, how do we taper them down. Having a community and training is so important. I went to the Integrative Psychiatry Institute in Denver. They have a year and a half long program. There are other programs that are very good. Polaris has one. If you Google IPI Denver, you'll find them.
A year and a half of that training. This is after you've gotten your doctorate
I was doing both at the
in
same
tandem.
Yeah.
That sounds intense.
Yes, it was. But I had the benefit of whatever I was learning, I was able to apply in clinic immediately. So
Work smarter, not harder.
in IPI, the way they do their programming, it's not just asynchronous, listen to this lecture. There were home groups, small groups that you could bring cases to. There were therapists, physicians, nurse practitioners, PAs. I really benefited from that community of, hey, what are you seeing? How would you handle this? And those relationships really took off. Unfortunately, our professional organization doesn't have a lot of psychedelic specific interest groups or resources.
There any at this time? I don't
I
think
don't
so.
think so. There's a guy in Oregon, Spirit Pharmacist. He runs a master of psychopharmacology that's psychedelic specific. So you can really do a deep dive into drug interactions and tapering. Your patients are doing this stuff, whether they're telling you or not. There are patients who are microdosing. There are patients who are doing mushrooms. We need to be asking. And yes, I'm in a ketamine practice, so that's a natural part of what I do every day. But there is some really unsafe, wild stuff that people are doing. PAs need to be educated about, or at least have a basic understanding of. Recreational use of MDMA while also being on SNRIs is not a great idea. So yeah, there are a lot of resources out there. The best part is there's a lot of cross collaboration between therapists.
When you say there's a lot of resources out there, do you mean drug interactions? How
Yeah.
to navigate what the research said? Because it seems like the research is still kind of up and coming.
Yeah, there are. So the Psychedelic Medicine Association, it's a membership-based model, so that might be prohibitive for some. If people reach out to me, I have a table of drug interactions. I'm happy to share. It is for informational or educational. Spirit Pharmacist, a pharmacology professor at Oregon, has quick and dirty webinars designed for prescribers about psychedelics, medications, things to be aware of. His name is Ben Malcolm.
Sarah, as you're talking, I'm trying to compile all these resources. One of the reasons why I really wanted you here is I know that there's this whole industry happening. You're one of the few, if the only PA I know who's working in this sphere. I wanted to have a sense about what your process looks like. When I think of ketamine, I'm thinking that there's S-ketamine, the nasal spray. Is it infusions as well, or just specifically one or the other?
Yeah. So I will answer that question. Spiritpharmacist.com is the guy, and about Spirit Pharmacists. His name's Benjamin Malcolm. You had asked, what's my process and what's the clinical?
Like, I'm a patient. Hey, Sarah, help me out. Nothing's worked before.
I do not administer Spravato in my clinic. I am private, outpatient, no insurance. I work with compounded. So yes, I can provide intranasal racemic ketamine, oral, IM, and sub-Q. That is what I'm comfortable working with in my office. There are IV ketamine clinics in my area. And so if I have someone that I think a good candidate for IV, and I'll go through like what makes, like, why would you send someone to an IV place? There's already an IV place in town, so I don't compete with them because huge liability wise, IV administration is significantly more risky. The main benefit, so IM ketamine and IV ketamine, there's about a 7% difference in bioavailability. At first blush, someone might say, oh, wow, 7%, that's a lot. And it's not. They're essentially as bioequivalent. Your metabolism can vary 5 to 7% in a day. So it's a negligible difference in bioavailability, meaning how much of the dose is lost by normal metabolic processes. The main reason why I would send someone to an IV clinic, maybe they're being treated for pain, so they're going to need a higher dose than what I'm comfortable giving in clinic. Maybe they have severe PTSD or anxiety. With an IV, you can turn it off. With me, you get your dose, we're going on this ride. Most IV clinics do not include therapy or integration as their model. That's where someone like me really shines. But if you have someone who is not open to therapy, that's a good candidate for IV. I'm not going to push somebody into therapy if they are resistant to that. If somebody is on that cusp of needing an emergency referral or going inpatient and you're looking for rapid relief in symptoms, get them into an IV place. They can treat higher dose more frequently. The benefits of a practice like mine are that it's boutique, it's small. You're not going to be treated in a room with 6 other people. My whole setup is very, very much not clinical. It feels a lot like a living room when you come in. I have a kitchen, you can get a cup of tea. I don't want to work through my trauma on a vinyl bench covered in paper, staring at a fluorescent light.
I think about individuals needing ketamine and healing trauma, PTSD, severe depression that's treatment resistant, and it's complex. And I'm thinking these individuals themselves are already on edge. They're already probably gone through processes that they feel medicalized, like their symptoms not being taken seriously, or you got to take this medication and that's all I can do. So being able to create an atmosphere where it's about being in a safe place, not only you as this medical provider, but like calm and relaxing and comfortable. I love that type of thinking behind your business because that's how it should be.
Promotes healing rather than pathology.
Exactly. The way that I do billing, I also try to have the billing reflect what's actually happening with the clients. For example, an IM ketamine session, I book 2 hours out for. But if the patient needs 90 minutes, that's what they get billed for. I feel there's a higher responsibility when working with medications like this to meet folks where they are, not view it as a cash grab. I'm trying really hard to give people the time, space, the pacing that they need. A lot of our work is we do a lot of breath work, we do a lot of grounding, we do a lot of somatic body-based work to get folks. Ketamine is a dissociative. Some people find relief in that dissociative or floaty feeling, but integration is a huge part. Integration is all the stuff that happens after the trip, which is even more important than the trip itself. What is one's experience of being in their body? Many people are very disconnected from that.
I'm wondering throughout this process, are the patients generally seated? Are they lying down? Do they get up and move around? Variety of all.
Yeah. So for a typical ketamine session, patient comes in, my couch actually turns into a large mat elevated off the ground. We cover that we've got a waterproof pad, and then we have a sheet that goes over that. So patient is lying down for the actual ketamine treatment itself. Eye shades are on, music is playing, the room is cool and dark. We start each session with the patient sitting on the floor, crisscross applesauce if they can. We're doing some breath work, just getting them grounded. Then we'll transition to lying. The typical side effect of ketamine is that people can feel kind of dizzy or woozy afterwards. So we do really slow transitions, getting them up. Another benefit to a clinic like ours is that we gently open the drapes and let the light come in. It's very gentle, like, okay, let's get some natural daylight in. Would you like a glass of water? Do you want to go to the restroom? Do you want to hang out in the waiting room or the kitchen for a while? Ketamine is like fresh powder on the mountain, and it keeps you from getting sucked back into old patterns or routines, same ways of going down the mountain. So if you want to cut a new path, you can. And so the treatment space that I'm trying to create is also looking to disrupt the pattern. Like, okay, your ketamine session's over. Let's not jump on your phone right away. Let's go outside and sit in the rocking chair and see what we see or hear a bird.
Being able to be mindful and present, switch mindset gears, all the mental constructs that have got you stuck. I describe it to patients that sometimes our negative thought process, we're on the same track over and over again.
Creating a
same
groove.
activity, behavior, and we're on this track on the snow. And it feels impossible to get off that track. How do we build another path? I love that analogy with what you said with ketamine. One of the things I wanted to jump into was Mate. Have you heard of that author?
Yeah.
I've read a lot of his books, and I know that some of his topics is controversial, right? With the psychedelics and healing with trauma. Gabor Mate is the author. What I got out of reading some of the books is a lot of the psychedelics goes back to history. My family's from Peru. So I have a lot of native Peruvian in my history and lineage.
I think it's important for PAs and society to take a minute and think about that there is a lot of talk of, will RFK approve MDMA or will we get psilocybin therapy? Ketamine is the only legal psychedelic. Psilocybin, ayahuasca, peyote are psychedelics that have been used for tens of thousands of years. A ceremonial, communal aspect. I think it's really important that while they are becoming medicalized, this is something that I really worry about, that it becomes, well, Sarah has all the answers. This drug is legal and Sarah can prescribe it.
Creating that space and presence, not something you get from a pill.
This too goes into my pricing model. I don't want to mess with making a quick buck over a drug that's been used for 10,000 years in really mystical ways. I don't know if karma's a thing, but I don't want to make a bet. So I try to be really thoughtful. I don't have all the answers here. At the end of the day, my mortgage still has to get paid. It's still a business. I have to make money. But I have such profound respect for the wisdom that I don't even understand 5% of related to use of these medicines. The more I went through PA school, the more disappointed I became that there is no magical answer.
No magic pill. There's no like, okay, now we're on, it's not that clear cut, unfortunately.
And there's a lot of social constructions that have made the medical institution what it is.
I have his book, The Myth of Normal. He wrote that with his son. I think that's a really powerful book. It is a dense book. It's not for the faint of heart. But, is that you are what you are seeking. You have the tools and the power to heal yourself. Just like you don't have to talk to a cut to heal it. The body has its own way of healing. But when you give it the right conditions, it will heal. You clean it out, put the Band-Aid on, make sure the edges are coming together. I think what Gabor Mate would say is that mental health is similar. Given the right conditions, the right setting, the right care, these drugs can help you heal yourself. The phrase is called inner healing intelligence or inner healer. That's a controversial perspective, right? There will be people listening to this podcast who are like, 100% woo, no thank you. This is my life. I find myself every day both trying to respect the woo, because that is fleeting, hard to grasp, leaves you with a sense of awe with these drugs. The evidence-based, the clinical care, you have to do both. Only focusing on one really disrespects the culture and the history and the tradition. These drugs
Really embody the art and science of medicine, what you're describing, like left brain, right brain, the whole integration. It's impressive.
There were really good pearls, and so I do recommend some people read it. The Myth of Normal was one of my favorites. I looked up on my Goodreads which ones I read. So I read In the Realm of Hungry Ghosts, Close Encounters with Addiction, When the Body Says No, The Cost of Hidden Stress, Scattered Minds, and Hold On to Your Kids, Why Parents Need to Matter More Than Peers. I've read all of those, and they're all like different takes of healing and trauma and managing this life. I think it gets more complicated as we get more ability to be on our screens and phones and order Amazon groceries. Like, it's a different world than decades, centuries ago. And so that's something to recognize, that things have evolved, and we still have to make sure that when we're practicing medicine, we're looking at the evidence, but also being respectful from the history and the wisdom in the Native American culture, for example. What can you tell a PA that might be interested in going into this type of work, working with ketamine? Where do they get started? What would be something you would encourage them to do?
I'm going to give maybe an unexpected answer. Two things come to mind. The first is do your own work. If you want to get into ketamine, explore the reasons behind that, or those reasons reflect your core self, your true values. I think that is so important. I have a book that has been transformational for me in how I think about stepping into power as a woman. Sometimes I'm uncomfortable with power. There is a book called Right Use of Power by Cedar Barstow. At first glance, it's a simple book, but the more you put it into practice, it is about how not stepping into your power is a form of power abuse. I think that could be particularly helpful to all PAs who find themselves in this profession of being second fiddle at times. That would be my first place to start. Reach out to others who are in the work. Learn what it's really like. From there, they'll be able to give you recommendations on this school or this program. It matters to some degree, but what matters is what you do with it and who you're connected with. How are you staying relevant? How are you digesting material?
How are you authentic in your life? That's what I'm getting out of this conversation. Authenticity, being vulnerable, and being able to connect what you're doing in helping others, how to move forward in our lives. You're at a great place in your profession, juggling being a mother and a woman in leadership. Very inspiring. I hope listeners will say, I can do it. I can do more. I can figure it out. I'm not perfect. But if I have a community of supporters, colleagues, and friends, you got it.
I look back on that time and I think, wow, it was like being in prison and I didn't even know it until I was free. I want everyone to lead full, fulfilling, free lives. If this message helps them do that, that would be really fulfilling for me. Thank you for having me.
You deserve to be free.
Thank you so much,
Amazing.
Sarah.
Thank you.
You provided your website, which is cantopsychiatry.com. So I'm going to spell that out. CANTO psychiatry.com. That's the best way to reach you. We'll try to grab all the resources you discussed today so we can keep on sharing it within our community. Thank you again for coming in, inspiring, being part of this community. And I am very thankful that I was able to work with you at APAP and continue this relationship in the psychiatry PA world. Thanks
Oh,
again.
you're welcome. Thanks for having me. I really
Yes.
appreciate it.
All
Completely
right,
honored to
guys.
have you. Thank you so much.
Bye.
All right,
Have a-
guys, that's a wrap.